Sit onsself met die opie. Right, welkom almal. Ek sien ons het almal 'n klompie mense hierso op die groep en ja, ek wil maar net sê baie welkom. Ek weet almal het seker verwag die volgende enetjie moet nou sê maar 3 weke later wees, maar ek dink met die aanpassings hier van die einde van die maand het ons besluit ons sal dit met 'n weekie aanskuif en ook om vir Christiaan te akkommodeer om wat vanaand so 'n bietjie met ons gaan gesels. So welkom Marlies. Ek hoop ek sien daar's 'n paar minder mense op die Google Meet. Ek weet nie hoe baie mense op YouTube kyk nie, maar hooplik vanaand gaan ons sommer van die begin af alles reg kry om ons op YouTube ook te stream. So kan ek miskien ook can I maybe just ask anyone on the chat at the moment that is that's solely English speaking? Maybe if I can just have a bit of an idea of our audience here tonight. Ons gaan sien wie se gesiggies is hier wat ons almal ken. So, ek hoop almal kan ons sien. Is julle reg? Daar's 'n duimpie en 'n waaitjie en alles. Alright, good, excellent. Dankie Sarmin. I know we will have, usually while we're busy, we might have a couple of people sort of joining in as time goes along. And I know I've had a couple of emails from people overseas also that asked about the timing of the discussion and so on. So yeah. Tonight we have Christiaan here with us. So Christiaan is one of our plastic surgeons that work with us and that are here sort of on site in the Panorama Center for Surgical Oncology. And we decided tonight we're going to chat a little bit about sort of I don't want to say breast cosmesis, but let's say breast cosmesis in the setting of breast cancer, because I think sometimes we tend to get so involved in the breast reconstruction and how the breast looks that we sometimes forget that in the end we're fighting a battle against cancer, which in itself, obviously is something that wants to take its toll. And in the old days, obviously patients would have had a flat-chested mastectomy and an axillary dissection, and I think the cosmetic result of those things were terrible. So we're trying to do better, but in the end, we still have to sacrifice some function and of the looks because of the cancer therapy that we have to do. So yeah, Christiaan has prepared a bit of a talk for us, or a bit of a presentation to give us a little bit of background on breast reconstruction. And I'm hoping that when we're finished, we will have a little bit of a discussion. So yeah, Christiaan, welkom.
Ja, baie dankie Ettienne, baie dankie vir almal wat inluister. Sal ons voortgaan in Afrikaans of gaan ons Engels?
I think let's do it in English because it's being streamed on YouTube. We might have people that want to sort of log in afterwards. I'm going to zoom in a little bit for you, and then what I'll do is there we go. And then I'm going to also, maybe you can give a little bit of an introduction. And then we can start the presentation.
Okay, well, the introduction is in the presentation.
Okay, so let's go for it. Let me just share our screen here. Okay. All right, fantastic. Here we go.
Okay, thank you very much. So essentially, the answer of the basics of the talk is in the name, and I try to keep it really simple in the sense that I think breast reconstruction is potentially an overwhelming topic, and it's partially because there's so many different options, and deciding which option which is fitting for each patient is probably quite a daunting task, especially if you don't have the context within sort of within making your own situation as a whole in the broad topic of breast cancer and breast reconstruction. So, just a couple of fallacies. Breast reconstruction it should never be a disadvantage to your oncological treatment. It should never be something where you ultimately or potentially compromise your oncological outcome. In the sense that you should be able to make a decision that essentially gives you the best of both worlds. So you should have good oncological outcome and also have the best cosmetic outcome for your specific situation. Also, in a South African context, some patients aren't always aware that medical aids actually do allow you those options. And different medical aids have different constraints and options that they allow. But in a broad sense, most patients actually have any option available to them to make a sensible and a good decision for themselves. Now, often the most daunting thing about breast reconstruction is deciding which is the correct route for you. And in all fairness, there are many different choices. There aren't necessarily bad choices and good choices, but ultimately it's about deciding in the individual with each person's personal preferences what is the best choice in that situation, in the context of their disease, and in the context of what they expect from breast reconstruction for themselves. So the focus should actually shift from not what is the right decision and the wrong decision, because there shouldn't really be right and wrong decisions, but rather which is the better decision for you or for the patient personally. So, you know, plan A versus plan B, and weigh up the different choices that you have available. So essentially, it's more a case of deciding which possibility is the route to go, rather than what is the right decision to make. And you will often find that there are many right options, and actually refining the different options for yourself is what ultimately determines the route that you should go. Now, um, just as a bit of background, breast cancer is a disease that's very well researched. And the implications of that is that oncological treatment should be fairly standardized wherever you go, whichever hospital you go to, whichever country you should go to. In theory, if you walk into a breast cancer unit in Cape Town, you should get the same options that you would get in a breast cancer reconstruction or a breast cancer oncology unit in New York. It's a well-researched topic, which means that in large trials, outcomes have been weighed, and we, by and large, know what is good for a patient and what is bad for a patient, and in certain contexts, which options are appropriate and which options aren't appropriate. And your surgeon should essentially allow you to facilitate your decision making and making a good decision for what the best choice for surgery and for reconstruction is. Um, Sometimes compromises are possible. Obviously, things aren't always black and white. There are sometimes some grey areas, and this is where experienced surgeon can also guide you as to what would be a good option in your specific situation. Um, Less is often more. Um, the perception that patients often have is that a bigger surgery is a more effective surgery, and that's not necessarily the case. In certain situations, of course, there are bigger procedures that are required, but in some situations, simple, smaller procedures effective and appropriate. And then a patient should ideally be an expert of their own disease and their own situation. And I think a surgeon's responsibility is not only to treat his patient appropriately, but also to inform his patient so that she knows what the best options are and she essentially can make an informed decision for herself rather than being forced in a certain direction. Um, can I just let off of my... All right. So essentially, I've based the whole talk on this flow chart. There's very little writing in the talk just because I want to keep things simple and I want it to be a visual presentation that you can follow. So essentially, breast cancer is at the top at the top of the screen, and all the different, almost simplified options that branch out from there. So breast cancer as a whole, in the old days, in the initial, the father of breast surgery, the father of breast surgery was William Halsted, and at the end of the beginning of the 19th century, he essentially developed surgical techniques and found that patients didn't respond well to his surgery, and he gradually increased the size of his procedures and found that patients actually did even worse. So he concluded that bigger procedures actually resulted in a poorer outcome for his patients. So less is often more with oncology, and specifically breast oncology. And a mastectomy in certain situations isn't better than a lumpectomy. And once again, it boils down to patient selection. So I often see patients that are good candidates for lumpectomy or breast conservation surgery. And then the question arises, but would a mastectomy not be better? And the simple answer is it doesn't necessarily mean that it's better. So the first part of the talk is about breast conservation and the options surrounding breast conservation. Essentially, breast conservation is a technique that employs breast reduction techniques. Now, there are a couple of things that have changed in medicine, but one of the things that has stayed the same are the breast scan or the breast reduction techniques. So essentially, it means that you use a breast reduction incision to extract the tissue that you need to get a good and a sound oncological outcome. But you employ the same technique to reconstruct the breast as you would with a breast lift or breast reconstruction. Now, essentially, the techniques or the incisions on the screen are the different approaches to a breast reduction, and each one of those can potentially play a role in the breast reduction or the breast conservation technique, and the resection and the following surgery. The largest of those is the upside down T, or the anchor incision. And essentially, if starting on the left hand side, it explains the technique. So in the first picture, it's called the Wise pattern. It's named after an individual, and but also commonly known as the keyhole incision. If you look at the picture on the left hand side, it's quite obvious why it's the keyhole incision. Essentially, to reconstruct the breast, you need three components. You need skin to cover the breast. You need volume to prop up the skin that is covering the breast, and finally, a nipple, which ultimately defines what a breast is. And various techniques and various adaptations can help you to get those three components by combining those incisions. In the second picture, it just shows that the nipple gets shifted up. The tissue in yellow is essentially the tissue that you would remove for breast reduction, but in the context of breast cancer, you can remove tissue from any part of the breast to actually effectively do your reduction. And then the last two pictures is just the closure, and obviously the typical breast reduction incision on the right hand side.
Christiaan, can I, Christiaan?
Okay, perfect. So essentially, the oncoplastic resections or oncoplastic reconstruction comprises a perfect marriage of oncological surgery and cosmetic reduction surgery, and essentially you have the best of both worlds if it's planned well and combined effectively. So in essence, it comes down to why not use what you have available before you consider doing a mastectomy and potentially losing tissue that you could potentially use for reconstruction. The idea is actually to essentially use tissue that's available and essentially recycle the tissue and recycle the parts of the breast which isn't affected by the cancer. The concept of not doing mastectomy and potentially retaining breast tissue um, it is potentially a concerning one, but the reality is that it is a well-researched topic, and this would always be for me a first prize. And I think if you have a moral compass, I think you always think what would you do for people that you care about, your own family. And certainly I wouldn't have any qualms in recommending oncoplastic technique for my own family. What I've done to simplify the different topics, because essentially you're comparing two different procedures with each other, is that I've summarized it as a pros and cons. Now, um, essentially, the advantages of oncoplastic reconstruction is that it boils down to one procedure. So you can, in one procedure, you can have surgery that comprises both a good oncological outcome as well as a good reconstructive outcome. The complication rate is extremely low. Whenever foreign materials and additional donor sites are involved, obviously the chances for complications starts rising. You retain your own tissue. There's no better substitute for breast tissue than breast tissue. You don't need implants. I think with implants, immediately there's additional potential problems that arise that won't be the case if you use your own tissue. It's a very fast recovery and fairly cost effective. Um, the cons, and this is probably the crux of it all, is what is the big disadvantage? The big disadvantage is that if you have breast conservation, it has to be combined with irradiation therapy. But in the greater scheme of things, it means that for 4 to 6 weeks you have irradiation. Irradiation is not painful. It's more the discomfort of having to go to oncological 4 to 6 weeks and go every day. But certainly after those 4 to 6 weeks have passed, you've got a huge advantage to other reconstruction options. Um, usually other procedures have other reconstructive techniques have more procedures. There's high complication rates. Implants are required. Um, there are donor sites, which adds scarring and potential morbidity. It's usually a longer process, and with more procedures, there's usually more costs. So certainly from a logistic point of view, and also from a cosmetic point of view, oncoplastic techniques are a very favorable approach. Um, in certain situations where a mastectomy is required, and that can there's many indications for a mastectomy, but it's also important to note that indications for a mastectomy is often relative. The most common indications are where you've got a very large tumor or very advanced tumor, especially in a patient that has a smaller breast, where you've got potentially recurrent breast cancer or diffuse breast cancer throughout the breast. We've got synchronous or more synchronous or so bilateral breast cancer, or breast cancer in more than one focus of breast cancer in the same breast, and obviously genetic reasons as well. In a situation like that, breast cancer, where mastectomy is mandatory, as dictated by a patient's diagnosis and the specifics of the diagnosis, mastectomy is indicated, and then the first question arises is, should immediate or delayed reconstruction be performed? Certainly the most simple choice to make is whenever it's possible is to have immediate reconstruction, and there are multiple advantages to having immediate reconstruction. The immediate you retain tissue that could potentially otherwise be lost. It combines two recovery periods. So essentially, instead of having oncological surgery and followed by a reconstructive procedure, it essentially combines two of those recovery periods. So it boils down to less procedures, potentially lower cost. In general, I think it gives a better cosmetic outcome, and also the psychological effect of not having a period in your life where you don't have a breast or where you have asymmetrical breasts. Um, the, the advantage of, or the sort of the facts that play a role in delayed breast reconstruction is basically the opposite. So often you lose tissue that you don't need to lose, which is more it's essentially skin. You've got a longer total recovery, more hospital stays and longer hospital stays altogether, more procedures, which boils down to higher cost, often a less favorable cosmesis, and the psychological impact is more pronounced. So whenever it's possible and feasible, and there are very few situations where it's not feasible, immediate breast reconstruction certainly takes preference over delayed reconstruction. If we follow our table down, essentially when the decision for mastectomy is made and the decision for immediate or delayed reconstruction is made, the next decision is which option is the most favorable. And there's essentially two different groups or two different choices that a patient can make. Alloplastic, which is a reconstruction using some type of prosthetic implant, and autologous, which is using your own tissue. Now, looking at alloplastic reconstruction, essentially there's two different options, and it's immediate, where you use an implant straight away and go to a permanent implant straight away, and then option where there's a staged or immediate delayed reconstruction, we use a tissue expander initially and then eventually move to implant. If we look at the single stage implant reconstruction, implant is placed immediately during surgery. During the mastectomy, enough tissue is retained to allow tissue coverage or the coverage of the implant with viable tissue. Depending on patient specifics, you may choose to put the implant below the muscle or above the muscle. Certainly, there are options available again for a patient depending on their specific situation. And I think that this is something that needs to be personalized and discussed between the surgeon and his patient to decide on balance which would be the most favorable in a specific patient's situation. The alternative is to use a tissue expander, and a tissue expander is used in certain situations. In a situation, firstly, when a patient has a delayed reconstruction and there simply isn't enough skin, the tissue expander is used to expand the available skin and create enough space for a permanent implant to be placed. And also during surgery, if there's any uncertainty about the viability of overlying skin and tissues, adding a large implant or the correct size implant could potentially put unnecessary tension on the skin and could make a difference between the survival of soft tissues and loss of soft tissues. In a situation like that, a tissue expander is a safe option where you can insert a deflated balloon, which then first allows the tissue to recover. At a later stage, you can start inflating that tissue expander until it's a acceptable size for the patient and for the surgeon. Obviously, in a situation like this, the patient can also dictate what around about which size she can go to, because in between expansion sessions, a patient can actually you can go a week or two, even longer, with the tissue expander in situ or in place, and you can decide whether the current size is large enough or whether additional volume is required. The injection itself is a percutaneous injection, so literally in the rooms, you don't have to go to theatre. We find a little port by using a magnet which isolates the port and allows you to inject directly into your expander. And usually a week or 2 weeks between sessions is more than sufficient to allow a patient to recover. And ultimately, when the desired size is reached, it's a simple procedure to go and replace the tissue expander, which is a temporary implant, with a permanent implant. A tissue expander's function is to be quite hard. It's filled with water, which is non-compressible, but the idea is that it actually has enough rigidity that as you expand it, it can expand the overlying tissue. So it isn't supposed to be soft. Ultimately, the placement of a permanent implant is a soft implant that will give a more natural feel, and will often patients say that it's more comfortable once the permanent implant has been placed. There's no specific time how long a tissue expander has to stay in place. Tissue expander can stay in place for many years. If it does eventually rupture, you can just go ahead and replace it with a permanent implant, and it certainly doesn't cause any harm for the patient. So once again, the reconstruction can be delayed until it's comfortable for a patient. It's always interesting to see different patients' approach. Some patients want to get their surgery over as quickly as possible and get it behind them. Other patients want to take a break after the oncological treatment has been completed, and certainly there's once again no correct or wrong answer. It depends what suits the patient's specific needs in that situation. And then moving across to the autologous or reconstruction, which essentially means using a patient's own tissue. Now, there are two big different categories. There's flap surgery and lipofilling. And it's tricky to explain exactly what a flap is. And the best analogy that I can think of is comparing flaps versus lipofilling is looking at the seedling. So the flap is a piece of tissue that is or a piece of tissue that is based on a blood vessel. It's much like a seedling with a root. Essentially, you can take that seedling where it's growing, you can lift it out of the soil, and you can replant it in another place. And if the circumstances are right, and if the surgery is done well, the seedling, or the flap, as it were, will continue to live in the place where you transplant it. A simple example is from the lower abdomen, where a piece of tissue is raised, and that's the deer flap, which we'll discuss a little bit later. That tissue is elevated on its feeding blood vessels and transplanted onto the chest wall, onto a blood vessel in the chest. And if it's the coaptation between those vessels is done correctly, the tissue will continue to survive there. Essentially, like a seed being transplanted to another area. Lipofilling is slightly different. I've gone a step back there to the bean phase before it germinates, and it's essentially you are sowing a lot of seeds into an area, and the seeds in this context is fat cells that you sow into the wound bed of the mastectomy or the breast surgery. And if done in ideal circumstances, each one of those little seeds will almost germinate or survive and add volume to the underlying tissue in the breast. The two are quite contrasting and quite different, and the components of each, the advantage of one is the disadvantage of the other. And I think it's a common trait in breast surgery or breast cancer reconstruction options, is that there's pros and cons to every single procedure, and ultimately patients take the choice that is an advantage to them, where the accompanying disadvantage doesn't really apply to them. So, for instance, a flap is a very long procedure, but it's a single procedure, whereas lipofilling is short procedures, but it's multiple procedures. For some patients, going for a long extended procedure is not an acceptable choice. For others, going for multiple small procedures won't be an acceptable choice. And ultimately, it boils down to personal preference. Flap in general is a long procedure, it's a single procedure. It's quite a lengthy hospitalization. Often the first couple of days are spent in an ICU or high care environment, usually 3 to 4 days, and then possibly another couple of days in the hospital following that. It's a longer recovery period. It has a higher complication rate because it's a much more complex reconstruction. It has the potential for donor site morbidity because ultimately you are operating in more than one place. You harvest tissue from one area, for example, the lower abdomen, and obviously you operate on the breast at the same time. And you don't get donor site complications if you don't have a donor site, and so it adds to the complexity of the procedure and the potential complications. Ultimately, it has a fairly good cosmetic outcome, but it has the advantage. Why would you do this big procedure? Because you can transfer significantly more tissue in one operation. Liposuction, as a complete contrast, is done as a day case. It has a very rapid recovery. It has a low complication rate. There's minimal donor site complications. Patients tend to be bruised and uncomfortable for a couple of days, but that recovers quite quickly. It has a good cosmetic outcome. And the difference is you can only transfer small volumes at a time. So multiple sessions is required to get a good outcome. If we look specifically at flap reconstructions, there are various different options, and depends on the donor site. Ultimately, the DEB, which is in the middle on the left-hand side, is quite a favorable choice because it uses non-functional tissue. Most of the other areas use potentially functional tissue or have an impact on underlying muscles. So latissimus dorsi at the back, superior gluteal artery flap, and transverse upper gracilis is all are limited by potential donor site morbidity, placement of scars, and also the ultimate volume that you can transplant. The DEB uses fairly non-functional tissue. In fact, it's a tissue that you would discard when doing a typical abdominoplasty. You usually have acceptable volume of tissue to do a breast reconstruction with, and ultimately the scar is well hidden below the bikini line if it's done correctly. This is just the explanation. The picture on the left-hand side shows how the tissue is lifted up on its feeding blood vessels. The middle picture shows where those feeding blood vessels are then connected to blood vessels in the breast itself, and then ultimately healing with the scar that sits below the umbilicus, and obviously the advantage of having your own tissue. Typically, an operation like this, especially if it's done on both sides, a single-sided operation generally takes between 6 and 8 hours, and a double-sided operation can often take 12 to 14 hours. And once that tissue has been transplanted, we go back to the analogy of the seedling. So you've actually transplanted that tissue from the lower abdomen onto the breast, and in under favorable conditions it will continue to grow in that environment. And then moving across to lipofilling. Lipofilling is the exact opposite in many ways. Commonly it's also known as fat grafting, so it works on the same principle as skin grafting does, in that if you apply a very thin layer of tissue and you put it in a favorable area, all those little cells will continue. Eventually they'll be starved, but within a couple of hours they start scavenging from surrounding tissue and ultimately develop their own blood supply and continue to survive in the wound bed or the area where they're placed. The nice thing about fat grafting, it's a little bit like Robin Hood. It steals from the rich and gives to the poor. there are very few patients that if they're honest with themselves, that don't admit to having a little area that is cumbersome and bothersome. And essentially it means that you can steal from one area and submit that tissue into the breast where it's ultimately more needed. Once again, the analogy of the many seeds. So what you're doing is essentially taking many little cells and distributing them throughout the tissues of the breast, and those cells will continue to grow if the condition is favorable. So there are many potential donor sites on the diagram. They say a donor site from the buttock, but the lower abdomen and the thighs certainly are areas that are quite generous with fat. And it's a simple injection where you inject fat into the wing bed. What is important is that if fat grafting is going to be an option, much like any other breast reconstruction option, it's important that you are aware of this from the start, because it will ultimately also dictate what option it will. Your initial choice will dictate the approach that your surgeon takes with your initial cancer operation. And as with all the other options, if the planning is done well from the start and it's executed efficiently, it has a huge advantage compared to a situation where a patient decides to take this route at a later stage. So ultimately, the general surgeon and the oncological surgeon that's involved in the surgery dictates a big role in breast reconstruction, because it's often not about the decisions that are not taken, but also about the decisions that are actually taken. Where to put your incisions and where to use residual tissue, because a little bit of residual tissue can play quite a big role in the long run. And then obviously the fat is injected into the breast itself to create a larger breast mound, and ultimately the result is quite an elegant and subtle change. It's certainly not an option for patients who need a big breast reconstruction, but it does remain an option. It can also be used in combination with the implant. And then finally, the so-called cherry on top, or the one of the parts that defines a breast is obviously the nipple. Often a patient that has a breast reconstruction where nipple reconstruction has not been done, it makes a huge difference when the nipple is placed, because it changes the whole complexion and the ratios and the balance of a breast. And nipple reconstruction has also evolved quite a lot over the last couple of years, and in past times patients were subjected to skin grafts which weren't very reliable, and also ultimately didn't give rise to very good cosmetic outcomes. And with the advent of tattoos and people practitioners who specialize in nipple tattoos, patients certainly have very good options. So there are surgical options and just straight tattoos. The surgical options actually create the actual nipple, and then the areola is tattooed around that. And there are various different techniques. It ultimately involves reappropriating the little tissue flaps. It's once again local tissue flaps where you rearrange tissue to create a little nipple mound. And once that is healed, the tattoo can be done around it. And the other option is to go for straight to a tattoo and not have nipple reconstruction. What ultimately guides the decision of whether you should have a flat nipple or an elevated nipple is, what does the nipple on the other side look like, and what does the contour of the breast look like? Is it worth adding scarring to if there is a very well contoured breast? Does it make sense to add a scar in a situation where it's not necessary? And also, if a patient has a very prominent nipple on one side, for cosmetics and for symmetry, it's important that patient when she's wearing clothes that if there is a nipple that's protruding on the one side, that there is a protruding nipple on the other side as well. But the outcomes are quite good, and it ultimately depends whether a patient is willing to undergo another surgery. That's two examples of a flat tattooed nipple. So that is a patient that had a beard flap reconstruction, and the giveaway is the scar at the top, and then the nipple tattoo is done in a way that's after 2 sessions of tattooing. Initially placing the color, and then later adding depth by adding shading and a little bit more detail to the nipple reconstruction. And that is essentially my topic.
Excellent. Let's just climb off the wagon here. Thank you very much, Christiaan. So I am going to today, I mean, normally I'm quite happy if you guys want to unmute your mics and ask a question it would be nice to have a little bit of discussion. Let me just quickly close this and maybe just change this a little bit on our close that one, and then can make this one bigger, and we can do that. All right, fantastic. So now the YouTube visitors are back online as well. I see we have had let's quickly see. Yolanda said, what is the effect of radiation therapy on a tissue expander or a breast implant? So, Christiaan?
Okay, so ultimately, irradiation therapy is one of the reasons why you might consider placing a tissue expander rather than an implant in the first setting. So, it has been shown that a permanent implant generally doesn't survive so well. What it is exactly, whether it's the implant, the material itself, the fact that it's a solid material, a solid implant, or whether it's just that the implant that leads to tension on the skin, and then the irradiation, whether that ultimately leads to an adverse effect. But you can irradiate onto an implant, and you can irradiate onto a tissue expander. A tissue expander, the advantage is that there's not as much tension, so wound complications tends to be less, and also that because it's not a permanent implant, there is a revision surgery plan at a later stage where once the tissue expander is expanded, it's replaced with a permanent implant. So ultimately, you are discarding some of the results of the irradiation, firstly on the implant or the tissue expander itself, but also the capsule that tends to form around it. All transplanted or all implants develop a capsule. It's just usually more severe in the setting of irradiation. And then finally, about lipofilling. Lipofilling tends to be done after irradiation. It tends to have a very favorable effect. So it would not make sense to do lipofilling before irradiation. So it's usually you would have your surgery, the breast mound would be reconstructed by using the tissue that remains. So you don't necessarily keep breast tissue, but you can certainly keep some of the skin flaps and some of the subcutaneous fat and rearrange that. That would then be irradiated, and then afterwards you add fat. And fat tends to have a very favorable outcome on irradiated tissue. And certainly it's part of our protocol is to have all patients that get irradiation that we try to within 4 to 6 weeks following surgery or following the completion of the irradiation, they do get a session of fat grafting. And the idea is almost to arrest the negative effect of irradiation. Once you've had your irradiation, it's had its effect on tumor cells, and the idea is to limit the exposure of the remaining healthy cells or non-cancerous cells if they are, well, to limit the effect of the radiation and the sort of the prolonged effect. Irradiation is often a little bit like a slumbering dragon, in the sense that patients can be asymptomatic for many years and present at a later stage, often decades after the irradiation, with complications of irradiation. Ultimately, the idea of inserting healthy tissue into the irradiation field is to with the idea that you arrest that negative effect and almost protect your patient against future complications.
Yeah, maybe I just from my side to add that I always tell patients, remember the radiation is not going to have any direct effect on the prosthesis or the expander. That is an inanimate thing. You can irradiate this bottle of water, and it's going to go through there. It's going to sterilize it. It's going to kill the germs, but it's not going to do anything to the plastic. But radiation affects your tissue. And so the way that your tissue reacts to the radiation, and now there's a foreign material inside of it, and now that radiation will make that tissue sort of contract a little bit and form a layer of scarring around it. And that's what we call a capsule. And everybody has a capsule. If you put a foreign material into something, the body will always try and sort of shield that off from the normal tissue. But that should remain soft. If you irradiate that, it can become firm and hard and stiff. Not in everyone, but in a large percentage of patients. And I think that's I think an important thing. So whatever you put in there, you're going to have that effect. Whether you have a prosthesis in or not, you're going to have that effect on the tissue. The benefit is that once you've lost that volume, let's say you have a flat breast and you have a radiation on that tissue is stiff, and that tissue is not going to want to expand and want to go back to a normal size after the radiation. So I do think in our unit, I think we're quite progressive with the fat grafting early on after radiation, and I do think it does make quite a big difference in terms of keeping the tissue soft, because you're taking healthy unirradiated cells, putting it back into that area, and those cells can help their neighbors to heal and to recover from the radiation. So yeah, I hope that sort of answers the question, Yolandi. If you want to have a follow-up question, you're welcome to post that.
Just add one thing. The question is that it's the body's, as Ettienne said, it's the body's natural way of almost sealing off an implant. And why does a capsular contracture happen? Because that's often the sort of the next step is having a capsular contracture. Remember that scars are designed to pull tissue together. So if you have a cut on your arm, the body has to fix itself. It's before the advent of stitches, and it tends to pull together. Now, essentially what a capsule is, it's a three-dimensional scar that surrounds the implant. And if you can conceptualize a three-dimensional or a sphere around the implant, if that tissue contracts or shortens like you expect the scar to contract, that starts either making an implant feel hard. So even if an implant is soft, the silicone implant is usually soft. And the best analogy is looking at a rugby ball. A rugby ball is filled with water, but it's filled with air. And if enough air is compressed into it, it starts feeling hard. So obviously, if you've got a scar that contracts against a solid volume, it starts feeling hard, and that's the sort of the physiology or the rational of the sort of the explanation of why a breast becomes hard with a capsule.
I see Charmaine also asked, when does the expander, when does expansion reach its limit or its maximum? So, yeah.
Well, it depends on when a patient starts to expand. So, expander typically has a certain volume, whether it's 200, 300, 400 milliliters. So it has a capacity. It doesn't mean that you can't expand beyond that. So ultimately, at the time of surgery, some volume is placed in. So It depends firstly how much volume is placed during surgery, and that's determined by patient situation at the time of surgery. Is tension a problem for that patient, specifically for their skin flap survival? And then how soon after that do you start topping up, and how regularly do you start topping up? And possibly the best way of explaining it is that is if it's done at its most efficiently. So if you place the expander at the time of surgery, and for argument's sake, you are able to put in 100 milliliters or 150 milliliters, which I don't think is unfair. Often patients, in theory, you could start expanding 2 weeks following surgery, and add around about 50 mils per expansion session. And if that is done weekly, you can very easily expand the expander up to its capacity within 2 and certainly 3 months of its initial surgery. What is the ideal? I generally prefer not to expand too early following surgery, and I prefer to expand in little sessions, because expander essentially it follows the path of least resistance. So the idea is that the overlying tissue is lax enough that it can stretch and expand the skin. But it gets to a certain point if you expand too much and too often, where the skin is so tight that the chest wall then becomes more pliable than the actual overlying skin. So you don't actually want to expand the chest wall. So doing small little sessions a week apart, I think, is acceptable, and certainly 30 to 50 mils per session weekly would be more than sufficient. And if you look at the average side of an expander of 450 milliliters, and if you start with 100 milliliters, the remaining 50 mils, so it really is a case of potentially between 5 and 7 sessions, weekly sessions. So you can certainly do that within three months if you're eager to do it quickly.
Yeah, I want to show you. I've got an expander here, so you can clearly see it's got, it's also made of a silicone material like this. It comes out of the packet and it's empty, and it then has this injection port in front here, which has got a little sort of magnetic or a metal base in it. So if you have a metal detector or a magnetic detector, it can pick this up underneath the skin surface. And the idea is that, when you put it into the breast, it comes out completely flat. So we usually put a little bit of fluid into it at the time of surgery, and then afterwards you would expand this. Now this is a fairly small one. We get much bigger ones. You get up to 600 cc ones, and you can then obviously expand this progressively, and it will obviously stretch the skin out. In the beginning, when you put it in, you can see it makes folds like this, and frequently the patients can sort of feel these folds under their skin or on the skin surface, so it can be quite uncomfortable. So a prosthesis, on the other hand, let's just all right. The prosthesis, on the other hand, this is a typical prosthesis that we would put in sort of nowadays. Now the prosthesis is a much softer, much more pliable thing. It has got a fairly smooth surface to it, whereas this one, it's got a sort of a little bit of a textured surface. You can't see that maybe so nicely in the video, but it's got almost like a little sort of rough surface to it. The prosthesis is a completely soft surface. It's much more pliable. It does make a little bit of, does make little folds like this, but they tend to, when you put it in a breast, tend to sort of fold out quite happily. And again, you get this in a much wider range, from about sort of 100 or 80 cc one up to about sort of a 550 or 600 cc's. And they come in different sort of heights. This is the height of the prosthesis. They come in different widths. So you can sort of match that. But the thing is, once you put a certain size in, obviously that's the size you're going to have. If you want to change that, you're going to have to take the prosthesis out and replace it with another one. So for those of you who haven't seen a prosthesis, this is what they look like. And I mean, we use prosthesis quite a lot in our reconstructive work, because they're easy. If anything goes wrong with them, you can take them out and put another one in. If you've spent sort of 12 or 14 hours, putting a piece of tummy back onto a chest, and that doesn't do well. You're not so happy to just take it out and throw it in the dustbin. So yeah. So I think in principle from our side, or our unit policy is when you're dealing with cancer in the acute phase, you want to keep it simple, stupid. So you want to do procedures that are less than, let's say, 4 hours in length, because it's not going to impact on your immune system too much. Once you start doing exceedingly long procedures, it will impact on your immune system. In other words, your body's ability to fight things like infection and cancer cells will be impacted. And the concern is, if you have a flap that's struggling to heal and you have many weeks of treatment, it might delay things like radiation, like chemotherapy, and that can negatively impact your cancer survival. Now, you don't want your reconstruction to impact your cancer survival. Then we're missing the important target in this whole planning process. All right. Genevieve asks, can a DF flap reconstruction still be successful 2 years after a double mastectomy and 33 sessions of radiation?
Yeah, certainly. In my mind, the sort of place for free flap reconstruction is actually as a delayed procedure, and that can be done at any stage. It's a little bit of a which was first the chicken or the egg situation, because in a sense, when you've had irradiation and you've had a mastectomy, obviously the skin is quite tight, and there's usually not a lot of added tissue. And in that situation, you need to not only bring in volume. I said earlier that a breast consists of 3 components, so you need volume and skin. And the advantage of a free flap reconstruction is that you can bring in skin with your reconstruction, so that you don't only bring in volume, but you also bring the skin that covers the volume. So certainly there's no limit to how long after your surgery you can have a free flap reconstruction. The question is, are you a good candidate? Things that the surgeon will take into account is, do you have enough fat on your lower abdomen to actually to constitute a breast, and certainly do you have enough to be able to reconstruct 2 breasts, because obviously the piece of tissue needs to be divided into 2. But certainly the simple answer is certainly yes, it's the ideal setting. There's the one concern of doing free flap reconstruction with initial surgery, as Ettienne pointed out, is that it's quite a long and arduous procedure and quite a long recovery. And ultimately, you want to have surgery which allows you to recover quickly so that you can complete your oncological treatment. And there is a bit of a question mark about the long-term outcome in patients that have had free flap reconstruction as a primary procedure. Because obviously, if you take the same patient and subject them to a 2-hour operation versus a 14-hour operation, you can imagine that obviously if you do that often, the patients that have the quicker surgery is often gonna do better. And also, I think people confuse the idea that a more complex procedure necessarily leads to a better cosmetic outcome, and I don't think that's completely true. Certainly keeping things simple allows you firstly to have sound oncological treatment, and it does give good cosmetic outcomes. Flap surgery is amazing surgery when it's done in the right context, but it doesn't necessarily mean that it's a superior option to the other surgeries available.
Yeah, I think we see bad results with prosthesis, and we see bad results with DF flap. So breast reconstruction doesn't always work out perfectly, and that's why I always say, the good Lord knows how to make a breast. So if you can keep your own breast, that is always better. A reconstruction after mastectomy is always, I want to say, I always only do it if I don't have a choice of keeping the patient's own breast tissue. And I think sometimes people are in this under this impression like, no, let's just rather do a mastectomy and not do breast conservation. But the answer is, I think there are more people with bad cosmetic results from a reconstruction than there are people that have had oncoplastic or breast conservation procedures. So, yeah, I think to come back to Genevieve, I think answer is yes. Delayed tissue flaps, I think I would be happier after 2 years if I know the cancer's gone and people are doing well. Patients had a prosthesis for a few, for that period of time to then go and do a DF flap. But certainly I don't believe, in fact, I want to go as far as to say no woman should be told, listen, you have to have a flat mastectomy and then you walk like that for 2 years and then you go and come and have a reconstruction. That is 1975 thinking. In 2020, patients, unless you have a cancer that has grown all over the place and you are really having a life-saving mastectomy, again, which is something we very seldom see anymore, if you have to have a mastectomy for a stage 1 or 2 or even an early stage 3 breast cancer, you should have the option of having some sort of a reconstruction that you don't have to wake up with a flat breast. And I think that is an important thing. If your surgeon doesn't offer you that, then I want to venture to say that he is not working in a team that is really on par with what the world has to offer at this stage.
Just one thing I wanted to add is remember that a tissue expander is a temporary implant. Remember that a tissue expander can be replaced with any type of volume. So in theory, if you're a patient that has to have a mastectomy and you would like a deep reconstruction, the option is still there. How do you do it as a primary procedure? The option is still there to have a tissue expander placed, and after you've completed your treatment, have that volume replaced with a flap instead of an implant. The big advantage of that is if you do have irradiation, then you actually irradiate the tissue expander instead of irradiating the flap that took 14 hours to place in position. So essentially, it's the best of both worlds in that context. And also, I often tell patients that aren't sure, a tissue expander is a very safe middle ground because essentially it retains everything that you need to retain, but it doesn't commit you to a final outcome. So you can always, once you've completed your surgery and your treatment, you can come back and with a rational approach, once the oncological part has been sorted out, you can actually make a decision, and you still actually have all the different options available to you. You can still have fat grafting, you can still have a permanent implant, and you can still have flat reconstruction. So you don't actually burn any bridges by going the tissue expander or an implant route from the start.
Yeah, and I think the other thing that I always teach young surgeons is, remember, the cancer is not from the skin. You don't have to remove breast skin to be able to remove the breast cancer. And once you get that in your mind, it means you don't have to cut over where the cancer is. You can make a cut somewhere in the breast that is cosmetically better area. You can approach the cancer underneath the skin, remove that. So, I mean, there is no patient in our unit that just gets like a cut and chunk of tissue taken out and then just close it again. Every single patient gets a little bit of tissue moved in, an incision that is planned a little bit in a way that it would give a better cosmetic result. So our thought process is constantly one of, listen, okay, we want to get the cancer out. We understand it's going to cost you something. It's going to leave a defect, but you don't have to look like the jaw chewed, the dog chewed something off there, so you can still try and match things up so that it really looks well. So yeah. Any other questions from any of our participants? We've had a couple of people. Jy's welkom om jou microfoon te unmute as jy ietsie wil sê, ietsie wil bydra. I see some of the faces here. I know lots of you have had reconstructions. Some of you are with our unit. Some have had, not such good journeys with the whole thing. Ek sien Laurie knik haar kop klap hard. Sy's nou net deur 'n episode daar. So yeah. So yeah, anybody wants to share something or say something from their point of view? Almal is stoepstil. How's that, Laurie?
Yeah, I think from my side, I want to say to people that don't make a decision too soon. I think when you get diagnosed with breast cancer, you're in such a panic. Jy wil net alles gefix hê, haal af and fix it. I think 2 years down the line now, I think if I look back, one shouldn't make a decision too quickly. I wanted mine off immediately, but I mean, I know Dr. Ettienne suggested breast saving, you can't, don't take both off, and I think one should just breathe and not make a decision too quickly. So, yeah, listen to your doctor rather than thinking that you're going to die and you have to fix it all immediately. If I have to look back in hindsight, I probably would have made a different decision. Yeah, so I think for people that still need to or newly diagnosed and haven't had reconstruction or mastectomy, don't do the extreme immediately, because I think there are definitely other options, but just get through your process first and get it in your head that you're not going to die now, and the cancer's not going to kill you now, and then relax, and then listen to the people that suggest other options than going the extreme option like me.
No, but I still think, Laurie, thank you very much. I still think, like in your case, for example, I mean, I think you the typical patient that if you just went to the first, here's the doctor, he would have just done an old 1975 mastectomy with a cut sort of straight across the chest. So, even if someone chooses a mastectomy, there's a big difference between the mastectomies we do now and the mastectomies I still see patients coming in with, after all these times. So I think, I think it's not always a bad idea to say I want to have a mastectomy, but you don't have to have this sort of hollowed out chest with a scar that runs right across you can make the scar that is in the fold underneath the breast. You can do a bit of lipofilling just to create a little bit of a mound so that it still looks, when you have clothing on, when you buy clothing, it still looks good. So even a mastectomy can be done in a cosmetically sensitive way, or just like the quickest, cheapest, snide it off and gooi it weg type of option. And that, I think, is not something that is in any woman's best interest. I think it's not just about how it looks, it's also about the functionality of it and the discomfort that people have if they just have an old time type of mastectomy done as an afterthought. And I think, if you preserve skin, if you preserve the nipple, you can always go and remove it afterwards. But you can't put it back if it's gone. So that's why we say, if the option of putting something in, if it's available, use it. You can always go and take that prosthesis out. You can replace that prosthesis with fat. We have a few patients that said, listen, let's take the prosthesis out. Let's harvest some fat, put it back in there. I've had one or two patients that said, let me go and take it out and replace it with a DF flap. But the thing is, you haven't burnt your bridges. You've kept your options open. And also, I think the important thing is you got through your cancer surgery with a fairly short procedure, not a 14-hour, 15-hour operation. And I think that is quite important, that we don't lose sight of the fact that we're still battling a cancer that we don't want to allow to breathe that in any way. Iemand anders wat ietsie wil deel of wil byvoeg of wil vra nog? Everybody's half asleep this night, time of a Wednesday night. So, all right. Thank you very much, Christiaan, for a very sort of enthusiastic and all-encompassing talk on breast reconstruction. I think that's basically like a little summary of a breast reconstruction textbook. I know some of it might sound very sort of airy-fairy, but this is the type of decisions we have to do every day. So yeah, I hope it was valuable, and I hope, for me, it's an issue of, if one woman can be empowered to say, listen, I actually have a choice. I don't have to have this mastectomy, or I don't have to, sometimes you can choose between keeping your breast or having a mastectomy. Sometimes you have to choose between, I have to have a mastectomy, but I can have a reconstruction. And I think that is an important part of this whole journey, that we raise awareness, and that we are, that we help other people to say, listen, you shouldn't be bullied into a decision. I think I mean, sometimes we really try hard to give patients information so that they can make a choice under very difficult circumstances in their cancer journey. So ja. Ja, Marlies, enige laaste woorde van jou kant af, bemoedigende woorde?
Ja, ek dink ek stem maar net saam met Laurie dat mens moet maar net eers besef op daai oomblik as jy 'n akute stresreaksie as jy so 'n diagnose kry en jy is dalk nie in die beste posisie om dan op daai oomblik helder te dink nie. Dat mens net eers net 'n bietjie soos jy sê, Laurie, breathe.
Ja, ja, fantasties.
En rustig die experts se opsies oorweeg voordat jy besluit.
Ek dink ook in Laurie se verdediging, ek dink ook dis natuurlik om te dink, jy weet beter is groter en ek dink ook daarso is jou keuse van jou chirurg is belangrik, want ek dink iemand kan terugstaan en sê, luister, we've seen this 100 times, jy weet, en mens sien dit nogal baie pasiënte wat oorgretig is om te veel en pasiënte voel, hulle gaan nie hulle bors mis nie, en dan besef hulle dit 'n jaar of 2 later, maar dit was waarskynlik nie die regte besluit nie. Ek dink die kollega wat altyd sê benoude katte vat benoude spronge en jy weet dat iemand jou kan aanmoedig en sê maar luister, moenie oorhaastig wees nie en sê altyd van die opsie wat vir jou in die toekoms nog steeds al die opsies beskikbaar het, moenie burre brand nie.
Alright, ek dink kan net vinnig hier so in die boodskapies, almal het eintlik dis maar net om te sê dankie. So ja, baie dankie vir die klompie van julle wat vanaand ingeskakel het. Ons is so 'n bietjie minder as wat ons gewoonlik is. Ek weet nie omdat ons nou uit ons 3 weke siklus uit was nie, maar ons volgende aand gaan weer wees dan, ek dink is die 30ste oor 3 weke van nou af. So ons hou maar weer nou by die 3 weke, dan ek dink ja, dit is die 30ste September. Ek sal dit weer op ek probeer nou maar so af dat ek die PAC se webwerf, as jy op daai support groep knoppie klik, dan sal dit dalk weer die nuwe datum gee en jy kan maar net weer daar so inlink. Ek sal nou weer eens kyk hoe die YouTube stream gegaan het of daar groot glitches is, dan sal ek dit maar 'n bietjie edit. As dit baie sleg is, haal ek dit maar net af en dit maak maar of van niks gebeur het nie. So dan is julle net ons enigste witnesses vir die aand. So ek hoop julle het 'n baie lekker aand en 'n baie lekker week en 'n geseënde week. So ja, lekker bly almal hoor.
Baie